one quite useful tip that one of my plastic surgeons uses actually is if for example, a patient went back to intensive care and needed to remain intubated, they go back to, because they have significant airway disease that we were doing stereotherapy on, they would actually maybe put a cuffed endotracheal tube in. I know we don't use cuffed endotracheal tubes in small children, but to put a cuff tube so you could actually test the airway and you could release the cuff and see if the child was okay when you release the cuff, to decide perhaps it may be one indication it's okay to remove the tube. It's not, not foolproof by any means, but it is something that may be useful.
We're also talking that when we are close to the major veins, the anesthetist should always be by your side when you're injecting.
Well, I think we've got so used to actually asking anesthesia to be in the room when we're injecting alcohol that if we're injecting large amounts of foam, then we like them to be, not in another department. We like them to be actually fairly close by. Not for small volumes, it's okay. But certainly when we used to inject alcohol a lot, we actually asked them to be in the room when we were injecting. We tell them when we were injecting alcohol, because there's a big difference, when you're injecting alcohol to injecting sodium tetradecyl sulfate. You can hear the heart monitor beating faster. I have actually seen an arrhythmia in a patient, only once though. I've never been rendered any patients with alcohol I've never precipitated a cardiac arrest, fortunately, but I know colleagues have had patients have external cardiac massage, so having anesthesia there is very important. There is one report in the literature of an acute collapse using sodium tetradecyl sulfate. In her face, the second day we injected it. Okay, so I can remember the 30. Was it? Yes. It was, yes. And the second day, 24 cc's of foam into her face.
Her weight was on 60, half a cc, 30 ml of liquid, so double it.
So what was surprising was she didn't get hemoglobinuria after the larger dose, she got hemoglobinuria after the smaller dose. Half the patients who inject alcohol will get hemoglobinuria, and a significant number of patients who inject sodium tetradecyl sulfate will get hemoglobinuria as well.
It was scary, literally black, and we think that she's going to go renal syndrome.
I know of
so many there.
I know of one child who had ended up with acute tubular necrosis after profuse hemoglobinuria, but that is the only child. I've had one who developed a transient oliguric episode, but did not have any renal impairment, and after volume replacement and one dose of furosemide, everything improved.
So shall we get ready with the third case?
The third case is not a venous malformation. No.
Prophylactically, they run double the dose of fluid. So in adult, it's something like 250 ml is running per hour, even before, during the and just before starting the procedure. So that is the prophylaxis that we give. In case you see the urine turn black, then you alkaline. Otherwise,
if the urine turns tea-colored because of hemoglobinuria, all you need to ensure is the patient remains well hydrated. That will clear itself. Even the Coca-Cola colored urine can sometimes clear on its own. But we are more likely to alkalinize the urine if it's really heavily Coca-Cola colored and it's not clearing, given maybe a few hours, say 2 hours of good hydration, adequate hydration. So don't let the